Hello everyone, I'm Dr. Peterson with Regions EMS. We recently published an update to our patient care guidelines. In this video, I will go through the list of changes and discuss the implications to patient care. If you haven't seen the guidelines yet, there are 3 options to access them. Start by going to our website at regionsems.com/resources, where you'll see links for the full PDF version, the online web version, and the mobile app. If you already have the mobile app, the next time you open it, you will be prompted to download the update if you haven't done so already. All of the changes in this version can be found on page 3, What's New, in the Front Matter section. Here's what you need to know. Adult and pediatric pain control. There are 2 changes to these guidelines. First, we added a recommendation to reduce the dose of opioid pain medication if the patient is hypotensive. There's a myth out there that you can't give pain medication to a hypotensive patient. To be fair, morphine does vasodilate a bit through histamine release, but fentanyl and hydromorphone do not have the same effect. It's perfectly appropriate to be cautious and know that you can always start with a lower dose and give more. It's a lot harder to take back what's already been given if you go too high. So the guideline change is intended to encourage pain control for all patients and simply use a bit of caution when the blood pressure is low. The second change is to our ketamine dosing. Previously, we dosed ketamine for pain in the 0.5 milligrams per kilogram range, which is probably too high. At this range, patients tend to experience some of the weirder side effects without being dissociated, which creates a bad experience for everyone. The new dosing range is 0.1 to 0.3 milligrams per kilogram, or for simplified small, medium, and large dosing, it would be 10, 20, or 30 milligrams. This is consistent with local, regional, and national dosing of ketamine for management of pain. Adult VFib and VTAC cardiac arrest. Cardiac arrest management in the Twin Cities is an ever-changing target. We are literally on the front lines of resuscitation science, more so here than almost anywhere else in the world. ECMO is now well established in our clinical practice for shockable arrests, but we also believe that a patient's natural perfusion is still better than any CPR we can perform. There was a recent study out of Canada that compared several treatment options for refractory shockable arrests and showed significant benefit of both vector change defibrillation as well as a procedure called double sequential defibrillation. Defibrillation pads can be placed 2 different ways: anterolateral, which is our typical right upper chest and left lower lateral chest placement, or anterior-posterior, where the front pad is placed mid-chest, just left of the sternum, and the other pad is placed in the middle of the back, just left of the spine. Vector change involves applying a new set of pads in a different vector, while double sequential defibrillation includes applying a new set of pads, but then also delivering near simultaneous shocks through both sets of pads. This obviously requires a second defibrillator or AED. We will provide more details on the underlying science behind these procedures, but for now, consider either option when you have a patient who has been shocked multiple times, even if you've already activated the ECMO team. Like I said before, native perfusion is always better than CPR. Headup CPR. Most of you are probably not familiar with Headup CPR, but for those of you who have used the Headup CPR device, we've decided to remove this treatment from our guidelines. We've spent quite a bit of time reviewing and discussing the available scientific data and feel that removing this treatment is the right thing to do at this time. Please reach out to your clinical supervisor if you have any questions about this. Adult respiratory distress. Moving on to other guidelines, the Adult Respiratory Distress Guideline has been updated to recommend withholding epinephrine for severe symptoms if the patient is over 50 years of age. At this age, COPD is much more likely than true asthma, and the likelihood of cardiovascular disease is also higher. Since epinephrine is not helpful in treating COPD, the smaller potential of any benefit is outweighed by the greater potential for cardiovascular risks. Nebulizer treatments, corticosteroids, and CPAP will be the best treatment options for this age group. Adult weakness. A new guideline has been introduced to assist in evaluating patients with a chief complaint of weakness. This can be a frustrating complaint as it is usually very nonspecific, but it's also a very common complaint among elderly patients. The differential diagnosis should be broad and taken seriously, so this guideline provides a number of prompts to help you think through the possible underlying causes. Childbirth and complications. Although extremely rare, there is a possibility that you might encounter a significantly preterm delivery of a baby. For a child born earlier than 22 weeks of gestation, the expected rate of survival, even with advanced medical care, is less than 1%. We have added a reference chart to provide guidance on estimating the gestational age for these situations, which could potentially assist with clinical decisions. Midwife on scene. For other obstetrical situations, you may find yourself on scene along with a midwife who is attending to the patient. There is a spectrum of training and certification levels for midwives, so it's important that you understand their capabilities, as some midwives are able to prescribe and even administer advanced medications. We have developed a new policy to guide you in these situations, encourage you to partner with the midwife, and utilize their expertise appropriately. Medication references. The updated guidelines include several minor corrections and changes in the medication reference section. For any concentration of dextrose, the blood sugar treatment threshold has been updated to 70 in order to be consistent throughout the guidelines. Similarly, midazolam intramuscular dosing for adults has been corrected to 5 milligrams to be consistent with the rest of the guidelines. The ketamine reference has been updated to reflect the new dosing for pain management, as well as to remove a precautionary statement regarding increased intracranial pressure. And finally, a typo in the dosing of magnesium sulfate for eclampsia has been corrected to align with the seizure guideline. Critical care head trauma. Last but not least, for those of you authorized to utilize the critical care section of our guidelines, the critical care head trauma guideline has been updated to remove a reference to hyperventilation. It has been well established that we should not be hyperventilating head trauma, so this has now been fully eliminated from all of our patient care guidelines. That covers all of the changes in the most recent updates to our patient care guidelines. Our education team and clinical supervisors will be reinforcing these changes during CME sessions and case reviews, but do not hesitate to reach out if you have any questions. Thanks for all you do to take care of our communities, and stay safe out there.